Today is going to be part 2 of reviewing a highly cited junk paper. And what we're going to do is go over these two sentences right here and show why this is a false statement and why this one right here is a misleading statement. And we're going to review these four references that are in relation to these two sentences to show you why that is the case. So, why is this a really important topic to do a nitty-gritty deep dive into? Well, just recently, RFK Jr. sent Congress medical disinformation to defend the COVID vaccine schedule change for pregnant people, where RFK Jr. is basing the decision for this policy change on scientific studies that are unpublished and therefore not peer reviewed, are under dispute due to issues in methodologies or things like that, or it just simply flat out mischaracterizes other studies, where RFK Jr. is either cherry picking from good science or taking junk science to support his premises. Where the most egregious example was this one right here, where it was saying that a number of studies in pregnant women showed higher rates of fetal loss if vaccination was received before 20 weeks of pregnancy, meaning miscarriage. Where the literal author of the study was saying that the results of the manuscript were misinterpreted by RFK Jr. and their team, where ultimately controlling for all other confounding variables, they found no association between COVID vaccination and an increased risk of miscarriage. And why is that important? Well, it means that the basis of the argument of saying, oh, we're going to remove COVID vaccine availability for pregnant people due to this fact is incorrect. They're basing it on a false premise, which means that there should be no reason that pregnant people cannot get a COVID vaccination. And the reason we really want pregnant people to get COVID vaccination, particularly in the second and third trimesters, is because it's the only way for the mother to pass on COVID antibodies to the infant in a safe manner. And what we know right now is that between 0 and 6 months, that's a very high severe disease outcome window for infants when they get COVID infections, which means that it's highly desirable to actually vaccinate the mothers to protect the infant. All right, so let's actually dive into what we're here for. So let's start off with these four sentences right here. I initially was thinking maybe just starting with two, but let's do all four. So let's read this paragraph. In a meta-analysis study commissioned by the WHO, no clear scientifically graspable benefit of moderate or strong evidence was derived from wearing masks. While maintaining a distance of at least 1 meter showed moderate evidence with regard to the spreading of SARS-CoV-2, only weak evidence at best could be found for masks alone in everyday use, non-medical settings. And another meta-analysis conducted in the same year confirmed the weak scientific evidence for masks. Accordingly, the WHO did not recommend general or uncritical use of masks for the general population, and it expanded its risks and hazard list within just 2 months. While the April 2020 guidelines highlighted the dangers of self-contamination, possible breathing difficulties, and false sense of security, the June 2020 guideline found additional potential adverse effects such as headache, development of facial skin lesions, irritant dermatitis, acne, or increased risk of contamination in public spaces due to improper mask disposal. Saying that, hey, the World Health Organization is making this recommendation for mask usage, but they're not basing it off of any sound evidence, is what this is essentially saying. So we're going to be looking at sources 1, 2, 3, and 4. So if we click on the hyperlink of the source, it'll bring us down to the references. It's these ones right here. And I'm actually going to skip the April 2020 guidelines, focus initially on the June 5th guidelines, and then make a mention on why it's important to look at the publishing date, receival date, and other factors like that, because the World Health Organization actually published additional guidance on December 1st, 2020, and this paper wasn't submitted until March 20th of 2021, meaning that they had 3 to 4 months to actually review this document right here that was put out by the World Health Organization, which had even more details, but they didn't. They chose to exclude this information despite the fact that they were looking at multiple sources of this, which means that they intentionally left that out. Now, something we have to do when we're reading these documents is put our mindset into what it was at that time. So at the early stages of COVID, so this is about 6-7 months into the COVID pandemic, scientists from the CDC and the World Health Organization thought that COVID was predominantly spread by droplet-based transmission. So this is going to be your sneezing, your coughing. These are going to be heavy droplets that fall, contaminate surfaces, get on your hands and things like that. So at that time, the World Health Organization was really predominantly trying to push, oh, you need to be washing your hands, you need to be changing your clothing, you need to stay 6 feet apart, because we think that COVID is spread via droplet-based transmission. We don't think it's an aerosol-based transmission, meaning that it's not going to be lingering in the air, and that being in contact with that contaminated air or sharing air with people that are infected is really what's going to be driving the infections for COVID. At that time, they thought it was all droplet based, sort of like influenza, which is predominantly a droplet based transmission as opposed to an aerosol based transmission. We're starting to reevaluate that in terms of the literature, but even at this time, the consensus is that influenza is a droplet based transmission disease. So at that stage of the pandemic, they were saying that, yeah, absolutely, masks can be used, but because it's droplet based transmission, we really want to focus on other things such as compliance with hand hygiene, physical distancing, and then other infection prevention measures that would prevent human to human transmission of COVID 19. Where again, the emphasis was that COVID 19 was predominantly believed to be transmitted via respiratory droplets only and through contact routes like with the eyes, with the hands touching the nose, the mouth, basically all of these holes. That's how you're going to get it. But even at this time in June, the scientific community has been discussing whether COVID 19 might also be spread by aerosols, where they basically break it down into two categories. They say that in the absence of aerosol generating particles, in the absence of COVID being an airborne infection disease, you can use masks, but you don't have to, is essentially what they're saying here. But however, if COVID ends up being an aerosol generating particle disease where you can get infected from these aerosols, that healthcare workers should be wearing an N95 or FFP2 equivalent. And then related to the December 2020 guidance that was updated, there's a couple things that pop up right away. So the first is that they have this sentence that's carried over from the June 2020 document where it's saying that the use of mask alone, even when correctly used, is insufficient to provide an adequate level of protection for an uninfected individual or prevent onward transmission, source control, where they're again emphasizing hand hygiene, physical distancing, and etc. But what's important is that they included all of these mask management criteria to sort of emphasize the fact that, hey, masks are probably good for you, but if you're not using masks correctly, they can be a part of the transmission chain through these different means. For example, if your hands aren't clean before you're putting on the mask, that could cause infection. If the mask has holes and tears in it, then it probably won't be as effective as it would otherwise. If you're not wearing the mask correctly, it's not going to function properly. So if you're not having it adjusted to the nose bridge, making sure there are no gaps, that you need to avoid touching the mask while wearing it. They're advocating for not reusing a single-use mask. They're saying don't remove your mask to speak and don't share your mask with others. But already in this December 2020 document, they've updated it to show that, hey, at this point, we believe that aerosol transmission can also occur in addition to this droplet-based transmission, and that it has particular relevance in indoor crowded spaces that are inadequately ventilated, where infected people spend lots of period of time with other individuals, like restaurants, choir practices, fitness classes, nightclubs, offices, and places of worship, which is important because remember that qualifier from June 2020 where they're saying, oh, you can wear a medical mask, which is a surgical mask, so the baggy blues, if it's droplet-based transmission. However, if it's an aerosol-based transmission, which they're now acknowledging that it is, and we now know here in hindsight in 2025 that yes, it is both aerosol and droplet-based transmission that COVID is spread, with a predominance towards the aerosol generating particles to cause the transmission, that under that set of requirements, the WHO is saying that yes, N95 masks should be used. All right, so now that we've been grounded in this context, let's start picking these sentences apart. We'll start with this one right here. So, the WHO did not recommend general or uncritical use of masks for the general population. Well, that's just not true at all. So, in the June 2020 document, it has a whole bunch of guidance here for people saying like, hey, the general public, if you're sick with COVID or think you might be sick with COVID, you should wear a mask. Particularly if you have an occupation that is a high exposure risk, like social workers, cashiers, personal support workers, definitely consider wearing a mask. If you're a member of a vulnerable population, you should wear a mask. So like if you're immunocompromised, if you have heart disease, COPD, cancer, things like that, you should consider doing it. And it specifically states down here that the World Health Organization has updated its guidance to advise that to prevent COVID-19 transmission effectively in areas of community transmission, governments should encourage the general public to wear masks in specific situations and settings as part of a comprehensive approach to suppress COVID transmission. And at this time, remember that people were under lockdown orders. So the only people that should really be out and about are these frontline essential workers that we deem people at the time. So, like cashiers, grocery store clerks, DoorDash drivers, healthcare workers. Those are the people, the types of people that would be out and about. But for all those people, they're saying, hey, you should wear a mask. So, from that statement alone, I would say that this is just an outright false statement because they're saying, hey, look, these people should be wearing masks. And furthermore, in the December 2020 document that these authors had access to and would be aware of, it actually lists all of these different types of situations for the general public, where the table is titled Mask Use in Community Settings Depending on Transmission Scenario, Setting, Target Population, Purpose, and Type, where they're advocating for fabric or cloth masks for the general public in places like shops, shared workplaces, schools, churches, restaurants, gyms, etc., in open air markets, and the use of medical masks, which at that time they're considering more effective than cloth masks for people that are older, that are immunocompromised, if there's known or suspected transmission within the community, or really under any transmission scenario. So again, this is very definitive, saying like, hey, general public, you should be wearing masks. And then I find this sentence right below it to be highly misleading. So it says that the guidelines highlight the dangers of self-contamination, possible breathing difficulties, and false sense of security. So when we go to the June 2020 document, it says right here in bold, the potential harms and risks. So this is sort of a compilation of things that they found that could be potential scenarios that could make mask wearing less safe if people don't do it properly, which we've already covered. But again, it's important to note that some of these have some citations with them, but others do not. And when they don't have a source, that means that the committee just discussed this, said, hey, this is something we think could happen. Again, potential harms and risk, not known harms and risks. And they're saying we think this could happen, so it could give people a false sense of security, leading to potential less adherence to well-recognized preventative measures like physical distancing and hand hygiene. So it gives you a false sense of security, a false confidence that you can be closer to people when you should still be a distance away. And you'll see that that does not have a citation within it. So that again is just the committee discussing it, saying this could happen as a potential harm. 2020 guidelines found additional potential adverse effects such as headache, development of facial and skin lesions, irritant dermatitis, and etc. And it's saying it definitively that the guidelines found this. But again, the guidelines are potential harms and disadvantages. So these are things that the committee is thinking like could happen, not that they will happen or are known to have happened. Where again, they're saying that there is a potential for headache and or breathing difficulties with the caveat that it's depending on the type of mask used. No citation for that line. So this is, again, just a theory of something that could be an adverse outcome. And then here, there's the potential of facial skin lesions, irritant dermatitis, or worsening acne when used frequently for very long hours. So again, that's a caveat. It's not going to be like, oh, if you're wearing it out and about for your everyday stuff here and there, it's probably not going to happen. But if you're wearing it for very long hours, I'm guessing this is going to be for like 8 to 14-hour days, because it's probably going to be a source focused on healthcare workers, and you're using it every day, then this could be an outcome. But again, there's the caveat that there's a time component to this and a frequency component. And then the waste management issue that they also cited in there, again, there's no citation of this. This is just a theorized setting. This is a theorized way where contamination risks could increase by people coming into contact with contaminated masks in the trash, or picking them off the street and throwing them out if they're not disposed of properly. So this is again a very definitive statement. It's saying it found these things when it's really just a list of potential scenarios. That's what a harms and hazard list is. It's taking, these are some potentially known scenarios, and then these are some things we think could happen, and these are all the different outcomes where wearing a mask could be harmful, but again, it's potential. It's not known. It's not something that says this is definitive as a thing that can happen. And then for this reference 3, where it's talking about a meta analysis study commissioned by the WHO, saying that there's no clear, graspable benefit of moderate or strong evidence derived from wearing masks, and also that while maintaining a distance of at least 1 meter showed moderate evidence with regarding the spread of COVID, only weak evidence at best could be found for masks alone in everyday use in non medical settings. We have this reference from the WHO is actually the same reference where it's saying that N95 or similar respirators might be associated with greater reduction in risk than medical or cotton masks, but the study had important limitations like recall bias, limited information about the situations when respirators were used, and about the measurement of exposures, and most were conducted in the settings in which aerosol generating particles were performed. So this is the study right here. So it's reference 3, but also source 42. It's called Physical Distancing, Face Masks, and Eye Protection to Prevent Person-to-Person Transmission of COVID. And it's a systematic review and meta-analysis, where right off the bat, it's saying that face mask use could result in a large reduction in risk of infection, and that there was even stronger associations with N95 or similar respirators compared with disposable surgical masks or cotton masks, but they're assigning it low certainty, which we'll cover later on. So right off the bat, that's disproving this first sentence here. They're saying like, hey, there actually is a benefit for wearing a mask, and it's reducing the risk of infection. And that N95 masks are even stronger for this effect, where when the authors are looking at face mask versus no face mask, and they're looking at the chance of transmission for COVID for no face mask, it was around 17%. But when people were wearing a face mask, it was about 3%, which means that there's about a 14% reduction in risk, with the confidence intervals being between about 10.5 and 16%. And then, interestingly, when we look over to the physical distancing of greater than a meter, so for shorter distances, there was about a 12.8% chance of spreading COVID, but from further distances, this dropped to about 2.6%, where these error bars are overlapping. So actually, what their data is showing is that wearing a face mask is equivalent to going a further distance away from people in this analysis, and that the reduction in risk was about 10%. With the confidence intervals going from 7.5 to 12%. So this is showing that wearing a face mask versus not wearing a face mask has a higher risk reduction than physical distancing, which sort of goes counter to what they're implying here, showing like moderate evidence for one and then low evidence for the other. But then when we look to this note right here, so you'll see low and then there's a double plus sign over here, and it says the effect was actually very large and that the certainty of evidence could have been rated up to a moderate level, but they made a conservative decision to not do this and put it at a low level because of some inconsistency within the studies and the risk of bias. So while the effect is qualitatively very high, the precise quantitative effect is low certainty. So they're low confident in their ability to say that this has the effect that they're seeing because the studies were a little all over the place and how they were performed, the methods, et cetera, the people that were studied within them. And we can actually go look at this in their forest plots. So first, before we look at their forest plots, let's talk about where that bias and level of uncertainty is coming in. So they have MERS, SARS, and COVID-19 grouped within their analyses. You have different countries from China, Saudi Arabia, Vietnam, and then you have a mix of healthcare and non-healthcare settings. So these are a bunch of different variables. It's not uniform all across. So they're saying because of that, we want to lower our level of confidence in this. But however, when we're looking at the data for all of this, so first, what does the numbers down here mean? So if there is level 1, so this is a ratio, so this is going to be taking the effect of wearing a face mask versus not wearing a face mask. And if it's 1, that means there's no correlation, that basically if you wear a face mask or don't wear a face mask, it would be the same exact thing. There would be no effect. However, if we look at all of these studies, they're all favoring face masks. And then they even break it down. So N95 or similar face mask, respirators, and then surgical masks or cloth masks down here. And all of these, every single study is showing a positive effect of wearing a face mask on transmission of these three different viruses. With N95s having a much greater effect. All of these are much higher than the surgical and cloth masks. But the one that we really want to look at is this Wang et al. From China. It's specifically looking at COVID-19 in a healthcare setting, and look how high of effect this has. It's massive. So this study alone is showing that N95s have a huge, huge positive impact on reducing transmission. But all of these studies are saying that yes, face masks do reduce transmission. They're just saying that they're giving it a low confidence score because it's a mixed data set. They're looking at MERS and SARS, which are similar viruses to COVID-19. SARS was SARS-CoV-1. COVID-19 is SARS-CoV-2. That's why they're grouping these all together. And then, but for the one that is COVID-19 and they're looking at it with N95s, there is a huge, huge effect that has a 0.002 p level. It is extremely statistically significant. So this is showing that yes, masks do have an effect, which goes counter to what they're saying here. There was a very clear and scientifically graspable benefit, and that it would be at a moderate level of confidence. But due to the fact that it was like a mixed analysis, they rated it at low confidence. So this is false and misleading for this first sentence. And then the second sentence, if you actually look at the data, it's showing that there is basically an equivalency between the two, like both physical distancing and wearing a mask have around the same impact of preventing onward transmission. So they're both things that can be used positively to reduce COVID transmission. And then finally, for this last sentence here in this first paragraph we're looking at, that is just a mess. It's saying that another meta-analysis conducted in the same year confirmed the weak scientific evidence for masks. And this is that paper right here. So of note, we are in 2025, and this paper is still not peer-reviewed, which means that you have to take everything in this with a grain of salt, because if it's not peer-reviewed, it hasn't been looked at by other authors, validated for its methods, the accuracy of its findings, and etc. And we'll see that it has a lot of glaring errors, which is why this paper should not really be considered whatsoever. So first, they included randomized control trials and clustered randomized control trials, including people of any age, that tested the use of face masks, doing surgical or medical masks and N95s. And the majority of studies were unblinded due to the nature of the masks or insufficient information, where 70% of the studies that they looked at had a high or unclear risk of bias. Furthermore, the studies had poor compliance with wearing masks. So people were inconsistently wearing masks within these studies, which can influence the results, because you want to test if people are wearing masks versus not wearing masks, what are the outcomes? So if people are not being compliant to the study parameters of continuing to wear the mask for the designated period around people, then that's going to influence your study results, because you'll have a bias towards you'll just have a confounding effect, essentially, because if people are taking their mask off regularly and not wearing them consistently and they get sick, what do you do with these people in your study? Like, they're going to mess up your data. And they're even saying that, like, general discomfort in wearing the masks was not reported, and the general harms of the masks were not reported, which is something that this study that we're looking at would be interested in. So those weren't reported, and they don't have great compliance rates. So the data is already becoming lower and lower in confidence. And to sort of confound this even more, there's a lot of heterogeneity between the designs. So there's different stats that were run, there's different methods that were used, all of these things. And then the range of viral infections in the study is very limited, where it's focusing on influenza. So it doesn't even have like SARS-CoV-2 related viruses like MERS and SARS that we saw in the previous study. And then furthermore, the masks that they're using are not N95s or equivalent. They're just baggy blues, the medical masks that we've been seeing. So they're not doing that for aerosol generating procedures. So they're basically treating this like droplet transmission. And we know COVID is not just droplet transmission, it's also aerosol based transmission with a predominance towards that mode. So the study here just kind of like gets worse and worse and worse and worse because, to sum it all together, you have a low compliance rate, people inconsistently wearing masks, you have no COVID or COVID related viruses in the study. You have influenza, which is a droplet based transmission study. There were no N95s used for aerosol generating particles, which is what is needed for COVID. And all of this study designs are very different from one another. So you have very, very low confidence in any results that are being produced from this study. And to stack all on top of that, this is a preprint, so the study data was not reviewed. The methodology of how they performed their meta-analysis was not reviewed, which means that this paper should not be used as a source to justify anything. So to sort of summarize this review paper, right from when we start actually referencing some sources, the first line is false outright. The second line is false and misleading. The third line, there is no relevance of that paper because it is so weak in its presentation that it cannot be reliably used as a source. And we have false and misleading statements in the next paragraph as well. So that's all for today. Thanks for tuning in, and come back for part 3.